This is a discussion of the pharmacological effects of medication on the EEG and some cautions for training and some discussion of how to interact with clients regarding this issue. So, one of the issues about this topic is that medication effects, generally speaking, are quite different from person to person. And we've seen this clearly over the years, particularly with psychoactive medications like antidepressants, SSRIs, for example, seem to affect people quite differently, and the average number of prescriptions that are tried for a depressed client before finding the best fit for that client is usually approximately three trials, three different prescriptions are tried typically. And that's fine, but it suggests that the effect that medication has on one person may not be the effect that it has on another person. So coming up with standardized values of the effects of medications on the EEG can be a bit tricky. Now, why do we care about this? One of the reasons we care about this is that when we're doing an assessment, an evaluation using EEG, we do want to know if any of the medication the client is taking could be having an effect on the EEG that would skew those values and make them different from expected values that are associated with the medication effect rather than an intrinsic finding of that particular client's brain. This is particularly true when we're looking at a database comparison, because if we're looking at certain medication effects, it may cause one or another EEG frequency band to show as excessive or deficient. It might affect phase relationships, it might affect coherence, and so it's important to understand, at least to some degree, what effect these medications might have. Now, some of the medications that we're going to talk about do have fairly clear observable effects on that are similar on most people. For example, the barbiturates do tend to have fairly consistent effects from one person to another. But of course, dosage is quite variable, and as we've seen, for example, central nervous system depressants generally, like alcohol, seem to affect some people more strongly than they do others. And so some people can drink a small glass of wine and become severely intoxicated or even just fall asleep, whereas another individual might drink a large amount, even if both of them are somewhat naive to alcohol. So it's something that we need to pay attention to. There are 3 or 4 digital sources on your flash drive that relate to this. This paper, for example, is on your flash drive. Drug Effects on the EEG by Bloom. This is published in the Journal of Clinical Neurophysiology in 2006, so it's reasonably recent. It wasn't much that I could find that was much more recent than this. It's apparently not an area of a great deal of study, interestingly enough, although I'm told that the FDA requires that drug manufacturers provide them with evidence of having studied the effect of that medication on the EEG as part of the submission process. So the FDA apparently has this information, but it doesn't seem to have been compiled in any structured manner. So in Bloom's study, he talks about the factors to consider, of course, including the quantity of the medication, as I mentioned, the dosage, the method of distribution, the rate of metabolism. These can all affect the individual client's response to that medication. The the systemic effects of medication, hyponatremia, for example, which is a decrease in sodium levels, can cause effects on the EEG that are not actually directly related to the medication, but are an additional effect that some medications have on the sodium levels. And of course, as I said, unique genetic and or epigenetic patient characteristics. For example, if you're looking at the effect of barbiturates on an individual who is a chronic alcoholic, they may have a different response to barbiturates than does someone who is completely naive to central nervous system depressants. So these are all issues to take into consideration. Some of the basic changes that are associated with certain types of medications include slowing of the EEG background activity and some increase in beta from a lot of medications. For example, Dilantin and other anticonvulsants, benzodiazepines, do tend to produce this effect. So what do I mean by this? The slowing of the EEG background activity. When you're talking to an electroencephalographer or a neurologist, it's generally their description of the way the EEG behaves, and their terminology can be somewhat different than what we use in the neurofeedback field. For example, a neurologist would be looking at an EEG tracing, and they would be interested in the background activity, which is just the activity that's happening generally, and then any activity that emerges from the background activity is of interest. And so the background activity is considered the basis of the EEG, and this finding is suggesting that that frequency of the background activity, which in the waking person might be a certain frequency in the beta range, in the eyes closed individual it might be in the alpha range. This is suggesting that these medications can cause that to slow. Now, as we'll see in some of the subsequent slides that I'll be showing you, quite frequently medications, even those that you wouldn't expect to do so, will cause an increase in beta activity, and sometimes, in fact quite frequently, an increase in the fast beta frequencies. Now that seems somewhat unexpected, but we'll talk about that. Here again we have an increase in beta from barbiturates and benzodiazepines. Of course, the central nervous system stimulants like cocaine, amphetamines, and methylphenidate would be expected to stimulate the beta frequencies. These are the faster, more alert, more focused frequencies, if you want to give them a general description characteristic. What they are is associated with more localized processing of information rather than general communication sorts of tasks. So again, we have sort of what seems like a kind of a contradictory effect from barbiturates and benzodiazepines increasing the beta frequencies. Now, some medications can cause epileptiform activity or can contribute to epileptiform activity in individuals who don't have a history of epilepsy and or individuals who do have a history of epilepsy. These include the antipsychotics and even haloperidol, for example, which does tend to have a depressant effect or a sedating effect as part of its characteristic, but it appears to trigger epileptiform activity in some individuals. Clozapine, lithium, the phenylthiazines like thorazine, mellaril, compazine, and so on, and even the SSRIs can trigger epileptiform activity in the EEG. Now, this doesn't mean that it's causing an epileptic seizure, but it may be producing activity that looks epileptiform, like spike and wave activity in the EEG. Triphasic waves sometimes appear from toxic effects, and this is usually due to high doses and or patient intolerance to things like valproic acid, baclofen, lithium, levodopa, phenobarbital, and similar medications. So these are all somewhat odd findings that you would see in response to some of these medications. And again, it's only going to be seen in some clients and not in every client that's taking these medications. Now, ideally, you would do your assessment when the client has not been taking these medications, but for example, some of these, the anticonvulsants, for example, aren't something that the client cannot take. And so they need to be continuing to take that. The same is true of the antidepressants and several of these other lithium, for example, and other bipolar disorder medications. It's not appropriate to stop these medications. In fact, most of the medications that you can stop are those associated with ADHD. For example, the stimulant medications of various types, and some of the other ADHD medications that can be held, the morning dose could be held until after the assessment is done. This is a fairly common practice. This is a study by Knott, and this was published in 2000, so it's getting a little dated, but it's a pretty well done study. It's a study that compares the active medication with the placebo effect, and in this graphic we see the placebo effect as the 0 line and the effect of the medication as deviations in the positive or negative direction by frequency. And so for example, in the upper left corner we see the effect of neuroleptics on the EEG, and we see that it increases 3.5 hertz, which is their indicator for theta. I'm sorry, that's their indicator for delta. 7.5 hertz, which is their indicator for theta. 13 hertz is decreased, and that's their indicator for alpha. 20 hertz, which is their indicator for beta 1. 30 hertz is beta 2, and 40 hertz is beta 3, according to this schematic. So we have an increase in delta and theta, and an increase in beta 2 and beta 3 from this medication, generally speaking, in response or in comparison to the placebo effect, and a decrease in alpha activity and in beta 1 activity, which is interesting. Other neuroleptics, the haloperidol type of neuroleptics, are associated with a slight decrease in delta, slight increase in theta, slight decrease in alpha, a fairly strong increase in the beta frequencies, beta 1, 2, and 3. So again, we have a somewhat a medication that's considered somewhat sedating, actually having a increasing effect on the faster frequencies. Again, here we are in the hypnotics, and we have increases in all frequencies except alpha. And here we have a very strong decrease in alpha activity, according to this study, in response to this type of medication. The imipramine type antidepressants seem to cause an increase in delta, a decrease in theta, really no change in alpha or beta 1, but a small increase in beta 2 and 3. The disipramine-like antidepressants are showing a decrease in delta and theta and an increase in alpha. In fact, alpha is the only thing that's increasing from this type of medication as far as the participants in this study are concerned, with decreases in the beta frequency as well. And here we have again, we have what seems like a unexpected effect to tranquilizers, where we have a fairly strong increase in the beta frequencies, beta 1, 2, and 3, with a decrease in alpha and theta and only a slight increase in delta, in a medication that we would expect that would increase the slower frequencies and decrease the faster frequencies, because we assume that this has a calming effect. And yet the EEG frequencies associated with the response are more in the faster frequencies. Nootropics and hypoxidotics. So these are nutrients of various types. Seem to have a variety of effects, decreasing delta and theta, increasing alpha and the first two beta frequencies, slight decrease in the faster beta frequency. Psychostimulants, we would expect that to have an increasing effect, an activating effect, but it's interesting that it seems to increase alpha most strongly and beta 1 as well, and the rest of these frequencies are depressed in response to the psychostimulants. Now we expect it to depress the slower frequencies like delta and theta, but that doesn't seem to be the most pronounced effect here. The most pronounced effect seems to be in the alpha frequency band. So this is just one example of one study showing increases and decreases in these different frequencies in the treatment group compared to the non-treatment control or placebo group. This is another study showing somewhat similar results. Again, we have the sedative neuroleptics showing a positive activation of the delta and theta frequency band. So 2 pluses is a strong increase, 1 plus is an increase, a minus is a decrease, and a double minus is a strong decrease. The 0 means no change or no effect, or the effect is not typical. We have a strong decreasing effect in the alpha frequency from these sedative neuroleptics. These are also decreasing beta 1 but increasing beta 2. These are frequencies greater than 20 hertz. So here we have virtually every single one of these drugs causing an increase in the fast beta frequencies, and sometimes a fairly strong increase in the fast beta frequencies. Again, the hypnotics and the anxiolytics are causing strong increases in beta frequencies, and in some cases decreases or no effect at all on the slower frequencies. In fact, the hypnotics are showing a strong decrease in alpha, a strong increase in delta and theta, and a somewhat moderate, I guess I would say, increase in synchronization of the EEG. Quite a few of these cause the EEG to be desynchronized. Now again, back to our discussion of what language a neurologist or an electroencephalographer would use, the terms synchronization and desynchronization applied to the EEG are usually associated with rhythmic frequencies compared to lack of rhythmic frequency activity. So what do I mean by rhythmic frequencies? When you close your eyes, you have synchronous waves appearing as a result of the visual processing neurons oscillating in those slower frequencies, particularly alpha or the posterior rhythm. And so in the posterior rhythm, we see a great deal of synchronization. A lot of neurons are firing together in the same frequency, and this causes a very synchronous waveform pattern. Now when you open your eyes and start processing incoming visual information, that synchronization goes away, and you have what is typically called a desynchronized EEG. So this column that shows synchronization is suggesting that some of these medications cause the EEG to synchronize more, but most of them cause the EEG to synchronize less, to become less synchronized, more desynchronized. And those do tend to correspond to some extent with those that produce a decrease in alpha activity, with the exception of the sedative neuroleptics, which have a different effect. This is a more recent, well actually it's more recent than just the previous one, but it's from 2005. This is a fairly good paper. This is also on your flash drive. This is from the American Journal of Electroneurodiagnostic Technicians, and these are medications. It has a fairly comprehensive list of medications, as you can see, and a fairly good list of the effects of these medications. Placing this on the into the PowerPoint slides was a little bit tricky, and some of these columns don't line up properly after having done that. So you'll probably want to read this in the paper that's on your flash drive, where the columns do line up appropriately. But for example, let's take a look at alcohol, which we haven't seen in any of the previous slides. It's classified as a depressant, a sedative, a central nervous system depressant. The EEG effects tend to include chronic low voltage fast, lower amplitude and decreased frequency of alpha, diffuse slowing, increased delta, and theta, decreased alpha activity and frequency. So all of these findings are typical with individuals who take this, which again seems somewhat paradoxical, because we have a central nervous system depressant causing these kinds of more fast or increasing fast activity effects and decreasing the slower activity. In acute alcohol consumption or intoxication, we have generalized diffuse slowing, increased delta and theta. So that makes sense. But in the chronic consumption, we tend to have more of this low voltage fast pattern with lower amplitudes and decreased frequency of alpha. So alpha slows down is what this is saying. It doesn't necessarily decrease in voltage, although when you have a low voltage fast pattern, it's very common to see a decrease in amplitude of alpha. And actually, sorry, I see that it's saying that alpha amplitude and frequency is decreasing. Let's see if there's any of these other ones that we really want to look at that we haven't looked at. Benadryl, for example, the antihistamine category, seems to slow down the EEG. It has a sedating effect in many cases. We see that in this as well. Here we have Tegretol, a hypnotic sedative, which has a sedative hypnotic effect. It may increase anterior dominant beta activity. Here's Klonopin. Not much findings there. Coumadin. Interesting that that has an effect, a nervous system effect. Depakote has no consistent effect, but it does produce a decrease in epileptiform activity, and it produces seizure reduction. Let's see if any of these are... Again, we have no consistent effect. This is an anticonvulsant showing no consistent effect. Barbiturates causing increased beta activity, widespread frontal to posterior beta, decrease in alpha with high doses. We've got a bunch of meds associated with fluorothane, halothane, fluoxetine, Prozac, and so on, causing slow and fast activity, some paradoxical effects. So again, we have quite a few different classes of medications causing various combinations of effect. So this is something that's worth reviewing on your flash drive, because this is probably the most comprehensive resource that I was able to find. Again, we have the stelazine, for example. We have Valium causing high amplitude diffuse beta. Again, a somewhat paradoxical effect. Now this link is no longer valid. I just checked it before the class, and they must have forgotten to pay their website fees, because this is the skill database website and it's no longer valid. So I'm guessing they forgot to keep up their registration. Somebody got the email and just dumped it into their spam file. This used to be a nice resource. You could click on this link and it would take you to page after page after page of medications. It would give you the EEG effects, but it would also give you links to all the research associated with that medication, whether it was EEG related research or not. So it's kind of a loss that we don't have this available right now. I'm leaving it in the presentation because I'm hoping they'll pay their bill and get it back up. So when we have a discussion about medication, one of the things we want to be clear about is our scope of practice. When we're talking to our clients about medication, we need to be very clear that unless we are a physician, we're not in the business of prescribing medications or recommending changes in medication management. We don't want to be in the position of saying, well, neurofeedback will fix you so you don't have to take your medications anymore. Please do not ever say that to your client. Hopefully you all understand that that's not a good idea without me having to tell you. So how do we interact with our clients about medication? Well, one of the main things that we want to do is we want to alert our clients to the fact that the medication that they're taking may have a different effect on them after or while they're doing neurofeedback. So the neurofeedback training itself may change the effect of the medication or the patient or client's response to the medication. And there are a couple theories about this, but essentially what the thinking is that if you change the way the client's central nervous system is functioning, then the central nervous system response to the medication will be different. For example, if you have a child who has an attention disorder and you help correct that attention disorder through neurofeedback, then the possibility that they will not need that medication anymore occurs. And so if you're giving a medication to an individual who doesn't need it, they're going to start having side effects of too much medication. And so the thing that we want to talk to our clients about is, please be in contact with your physician. Please keep up with your physician. Let them know that this is a common finding when doing neurofeedback, that the need for medication can change, the client response to the medication can change, and therefore it's very important for the physician to closely monitor the medication management situation so that they can adjust the medication if needed. Be very careful that the client is not just planning to precipitously eliminate their medication. Often clients come to alternative therapies with the expectation that they're going to be able to quit their medication. Sometimes they do this because the medication isn't effective or it's giving them some sort of side effects that they don't like. And so their goal is to stop using the medication. And that may be just fine, but they need to make sure that they're doing that in conjunction with their prescribing physician, because very frequently individuals who are taking medications will have significant withdrawal effects, even from some medications such as antidepressant medications will produce a withdrawal effect. So there should be an appropriate withdrawal schedule planned with the physician and followed closely so that the client is under the physician's care and observation while they're doing this task. So if you are doing an assessment with your client, and if you're skilled enough, you could possibly recommend to the physician that the medication that they have prescribed for the client is maybe not the optimal medication for that client. Now you're running a risk here that the physician may not take kindly to this suggestion, but most of the physicians that I work with are happy to get this kind of feedback. Quite often I can look at an EEG assessment where the child has been diagnosed with ADHD and prescribed a stimulant medication, and I can suggest that because of the characteristics of the EEG that I'm seeing, a stimulant medication may not be the optimal medication for this child, and I'll put that in my report to the physician, but I won't suggest that to the client because I don't want to be in the position of telling the client what to do about their medications. So I always discuss with my clients the limitations. If they're on medications, I talk about the limitations of my scope of practice, that this isn't my area of expertise, and I'm not going to be prescribing or recommending medication changes, but I would be happy to talk with their physicians if they would like. Most likely it's going to be easier for the client to talk to the physician, and so I usually direct the client to talk to the physician directly. I always talk to the clients about their plans regarding medication. Are you going to continue with your current medication? Do you have plans? If the client says, oh, I'm going to stop taking my medication, and I say, well, okay, are you going to talk to your physician about that? And they say, yeah, oh, I've already done that, we're already in the process, then I'm fine with that. But if they say, no, I'm not going to talk to my physician, I'm just going to stop, then I won't actually do neurofeedback with them under those circumstances. So this is an important consideration. We need to talk to our client and interface with the physician if at all possible, provide information. Now, one of the things that you'll find is some neurofeedback clinicians will say they don't work with clients when they're on medication, and they have to be off their medications first before the clinician will work with them. I don't feel that that's appropriate. I'm happy to work with clients when they're on medication, although I expect that they will be doing this type of consultation with their physician, and if not, then I will not work with them. But in most cases, everyone is very amenable to doing this properly, and it's done properly. It works quite well, and the person can reduce or eliminate their medication in many cases, although not always, and usually the physician is happy to participate. So this is essentially the structure within which we talk about medication in terms of our interactions with our clients, and these are the effects that we can expect to see in medication. So if you're doing an assessment, an EEG assessment, be sure to refer back to some of these resources and take a look at what might be the effect of medications on the client's EEG when you're looking at the EEG, and say in your report, make note that the medication might be influencing the results that you're seeing in your assessment.